Good morning, everybody. Today, I would like to talk about hyperprolactinemia, diagnosis and management. First, prolactin is polypeptide hormone, was named for its ability to promote lactation in response to the suckling stimulus of hunger. Prolactin is polypeptide hormone, was named for its ability to promote lactation in response to the suckling stimulus of hungry young mammals. It's secreted mainly by lactotroph cells of anterior pituitary gland, but also it's secreted by another extra pituitary sites from the breast. For that reason, it increased during breastfeeding, if there's any lesion in the breast or if there is wall chest injury. From the ovaries, so we see hyperprolactinemia and polycystic ovarian syndrome. It's secreted by the brain, so we see hyperprolactinemia after seizures and CVA. From the placenta, so we see hyperprolactinemia during the pregnancy. And endometrium, so we see high prolactin level in endometriosis. Also, it is secreted by lymphocytes. Half-life of prolactin is around 25 to 50 minutes. And most of the circulating prolactin is cleared by the liver. 75% of the prolactin level metabolized by the liver. So it's increased in chronic liver disease or liver cirrhosis. And around 25% of the prolactin metabolized by the kidney. So we see hyperprolactinemia and chronic kidney disease, especially in stage 4 and above. Secretion of prolactin in the body has a circadian rhythm with higher level during the sleep and lower levels during wakefulness. But all the levels, big and nadir level, in the reference range between 5 to 25 microgram per liter. Over 300 different functions of prolactin have been reported. In women, prolactin is involved in follicular development and maintenance of corpus luteum. It acts in mammary gland, induce lactation and maintenance lactation also. In fetus, prolactin help bone growth and mineralization. In the adrenal, prolactin stimulates adrenal to secrete more androgen. For that reason, we see in some cases of hyperprolactinemia, acne, hirsutism, it increases aldosterone. So you see sometimes hypertension, it increases also cortisol. Also, it was because it's secreted by lymphocytes. It's postulated that the prolactin from lymphocytes is involved in immune response to stress and infections. Also, it was thought that prolactin involved in osmoregulation by increasing salt and water absorption by the small bowel and decrease excretion of sodium and potassium from the kidney. For that reason, sometimes we see edema in hyperprolactinemia patients. Regulation of secretion. Secretion of prolactin is regulated by many factors: stimulating factors, releasing factor, and inhibiting factors. Inhibiting factors mainly include the dopamine, somatostatin, and GABA. The main inhibitory factor is dopamine. Dopamine is transmitted by the portal vein, which is located in the pituitary stalk from hypothalamus to pituitary gland, and it's bind to D1 and D2, D2 and D4 receptors in lactotroph, causing down regulation of prolactin gene expression. So it decreases prolactin secretion from the lactotroph. Releasing factor include TRH, oxytocin, VIB, and vasopressin. So we see there's a relationship between hypothyroidism and hyperprolactinemia because TRH stimulates prolactin secretion. So any hypothyroidism, primary hypothyroidism, low free T4 by negative feedback will increase TRH. TRH, it works in thyrotroph and lactotroph. So it increases TSH and prolactin together. Also, estrogen can stimulate prolactin secretion. For that reason, in any hyperestrogenemia status like polycystic ovarian syndrome, pregnancy, we see hyperprolactinemia. Prevalence: biochemical hyperprolactinemia without symptoms can be identified in up to 10% of the population. The occurrence of a clinical hyperprolactinemia with symptoms depends on the study population. Around 0.4% in unselected healthy adult population, and around 5% among patients at the clinic family planning clinic. Among women who have amenorrhea, around 90% they have hyperprolactinemia, and 25% among women with galactorrhea, and 70% among women with amenorrhea and galactorrhea together, and 5% in men who present with impotence or infertility. Because of hyperprolactinemia. Sometimes we see mild elevation in the prolactin level response to physiological conditions, such like ovulation, pregnancy, breastfeeding, stress, exercise, nipple stimulation, or chest wall injury. But usually we see less than 100 microgram per liter. Sometimes there's underlying disease behind hyperprolactinemia. Mainly we focus in prolactin secreting pituitary or prolactinoma. Prolactinoma counts around 40% of pituitary adenomas. And we have two types of prolactinoma: macroprolactinoma more than 1 centimeter and microprolactinoma less than 1 centimeter. Also, so we have stock effect from cellular and paracellular lesion. As I mentioned before, that any compression or injury in the stalk of pituitary can cancel the inhibiting effect from dopamine, and that increase the releasing and synthesis of prolactin from lactotroph. Renal failure, especially stage 4 and above, liver cirrhosis, primary hypothyroidism, as I mentioned before, around 40% of untreated primary hypothyroidism have hyperprolactinemia. Polycystic ovarian syndrome, around 57% of PCO patients have hyperprolactinemia. Seizures, usually we see peak of prolactin level after 10 to 20 minutes of the seizures. And we can use that to differentiate between psychological condition and real seizure. There are some medication can increase prolactin level with many mechanisms, especially a main mechanism related to the suppress dopamine or increase serotonin. We have antipsychotic, antidepressant, antiemetics like metoclopramide, domperidone, opioid, antihypertensive, verapamil, elfamethil, dopa also. Usually we see verapamil and elfamethil, dopa. Sometimes beta blocker, but it's not common. Clinical features of hyperprolactinemia. Hyperprolactin levels mainly affects two systems, reproductive system and skeletal system. In women, high prolactin level will suppress GnRH, and that will suppress LH and FSH secretion from the pituitary, and that will suppress estrogen and progesterone. Results in amenorrhea, oligomenorrhea, decreased libido, infertility. Hyperprolactin level acts in mammary gland and induce milk production, so it causes galactorrhea. Around 90% of patients women who have hyperprolactinemia, they have galactorrhea. On the other hand, around 25% of galactorrhea patients, they have hyperprolactinemia. Also, high prolactin level can manifest by acne, hirsutism. As we mentioned, it works in the adrenal gland. In men, high prolactin level in the same mechanism will suppress GnRH, LH, FSH, and testosterone, leading to reduced libido, erectile dysfunction. Rarely we see galactorrhea and gynecomastia. Indirectly, by low testosterone or hypogonadism, we see decreased muscle mass, decreased energy, and anemia in some patients. Bone manifestation. As we know that hyperprolactinemia causes hypogonadotropic hypogonadism. And it's well known that hypogonadotropic hypogonadism has negative impact in the bone health, causing osteoporosis and osteopenia. On the other hand, regardless the hypogonadotropic hypogonadism, regardless the gonadal function, there is effect related to high prolactin level by itself. In vivo study and animal studies showed that high prolactin level will stimulate osteoclast and cause osteoporosis and osteopenia regardless the gonadal function. And there are many studies confirm that. One case control study showed that vertebral fracture risk increase in high prolactin level compared to the health control. Around 43.6% of prolactinomas patients, untreated prolactinomas patients, have vertebral fracture compared to 4.8%. There's benefit from treatment? Yes. One systemic review and meta-analysis studies showed that vertebral fracture rates were significantly lower in treated prolactinomas versus untreated patients with prolactinoma, regardless gonadal function or recovery from hypogonadism. Diagnostic approach. Current guidelines states that serum prolactin can be drawn at any time of day. Exercise, eating, and nipple stimulation should be avoided for at least 30 minutes prior to testing. When we read the test, we have two important phenomena or effects, Hook effect and macroprolactin. Hook effect is encountered in the presence of excessively high prolactin, which saturates the antibodies used in the two-site immunoradiometric assay, leading to artificially low prolactin values. And it can be overcome by repeating the assay on 1 to 100 serum sample dilution. So when we see big adenoma in the pituitary with low prolactin and patients present with symptoms of hyperprolactinemia, so we have to think about Hook effect because all the antibodies saturated by prolactin level. So only dilution, the sample will give the true level of prolactin. We have macroprolactinemia. Most of the circulating prolactin in the blood is monomeric, which weighed around 23 kilodalton, which is biologically effective or active. Around 85% of the prolactin in the blood, it is monomeric. There's another form of prolactin, which is big prolactin or dimeric prolactin. Usually it weighs around 45 to 60 kilodalton, and it's less effective. And there is another form which is called macroprolactin or big prolactin or large prolactin. Usually it weighs around 150 to 170 kilodalton and usually is polymeric. It's considered as inactive form of prolactin. So sometimes we see high prolactin level and patient is asymptomatic for hyperprolactinemia and there's no other reason for that. And LH, FSH, estrogen, progesterone, all is normal. So in this case, we have to think about macroprolactin. The size of prolactin particles is big. For that reason, the device is treated at hyperprolactinemia, but the active prolactin is less. So we suspect hyperprolactinemia in these cases, and we suspect that if there is 30 to 60% of total prolactin in the blood are macroprolactin isoform. It's very common actually. Around 10 to 35% of hyperprolactinemia case is macroprolactinemia. It's very important to recognize this condition to avoid misdiagnosis, unnecessary intervention, and treatment. It's not detected by normal blood assay. Usually, we need to do the test prolactin measurement by gel filtration chromatography. Diagnostic algorithm. When we start the workup for diagnosis, we have to think about the two important causes, prolactinomas and non-prolactin causes, non-prolactinoma causes. Actually, there is no clear cutoff can distinguish between prolactinoma and non-prolactinoma causes. But usually we consider that 100 microgram per liter is good cutoff to distinguish between them. Usually if the prolactin level more than 100, it's highly suggests there is a prolactinoma. More than 500, it's confirmed there is macroprolactinoma. More than 25 microgram per liter, it's highly suggests, or 99%, it is microprolactinoma or macroprolactinoma. On the other hand, if prolactin level less than 100, before sending patient to imaging, we have to rule out other causes of hyperprolactinemia like hypothyroidism, polycystic ovarian syndrome, renal failure, kidney, liver failure, or medication. So if patients taking medication which will known to cause hyperprolactinemia, the first step, it's better to stop that medication 72 hours and repeat the test. If that is not impossible because patient will have recurrence from his underlying disease, it's better to send patient directly to imaging. So if we see there is adenoma and usually microadenoma and prolactin level less than 100, so there's a question mark. It's a prolactinoma or not? In one study that 226 adenoma in pituitary with prolactin level less than 100, 99% was non-functioning adenoma by histopathology after the surgery. So usually to say this is micro or macroprolactinoma, we need to confirm that prolactin level more than 100. Other than it is non-functioning adenoma. And some medication like haloperidol, risperidone can increase the prolactin level more than 100 also. But this is general. Now we have to think about rare causes. If patient had hyperprolactinoma, symptomatic hyperprolactinoma, and there's no macroprolactinemia, and there are no cases, no causes for hyperprolactinemia, we can consider this as idiopathic hyperprolactinemia. And around 30% of idiopathic hyperprolactinemia will achieve spontaneous normalization with the time. So if the patient does not have any significant symptoms and we decide this is idiopathic hyperprolactinemia, it's not necessary to treat right now. We can monitor only. Also, we have very important case, which is rare, long-standing and treated deep hypothyroidism. As we mentioned, that long-standing free T4 will stimulate hypothalamus to secrete more the TRH. TRH stimulate thyrotrope and lactotrope to secrete prolactin and TSH. And that can cause hyperplasia in the pituitary, mimic pituitary adenoma. And this is case report published in New England Journal of Medicine. A child 10 years present with severe hypothyroidism with hyperprolactinemia. The imaging showed that something like pituitary adenoma, but we can see there is diffuse enhancement that suggests hyperplasia more than adenoma. In this case, it's called pseudotumor, and no need specific treatment for that. Only treatment of hypothyroidism. After 6 months of the thyroxine administration, we can see normal pituitary. So, if we did not find if the prolactin level less than 100, if the prolactin more than 100, it's better to send the patient directly to imaging. If prolactin less than 100 and we don't have clear cause for that, it's better to send patient to MRI of pituitary with dynamic contrast to rule out cellular or paracellular lesion after ruling out all causes of hyperprolactinemia. So this is the algorithm of diagnosis. Overall, first thing, we have to rule out pregnancy in any hyperprolactinemia cases. And that's very, very important. Actually, last year, patient...
रूम 3 में हो, हम निकालता हूँ, आ जाओ हटाना फैन का।
Actually, last year, patient came to me for third opinion. She had amenorrhea, then seen by gynecologist. She did the test for the pregnancy. It was negative. Then referred her. She had hyperprolactinemia. Referred her for the endocrinologist. Endocrinologist start for her cabergoline. There was after 2 months there was no improvement. Prolactin is still high. He did for her MRI for pituitary. It was normal. Then she shifted to another endocrinologist. He did a full panel for hormone. He found that prolactin is increasing continuously, and he found that estrogen high also. So he told her it's better to rule out any tumor in the pelvis. So he sent her to do MRI for the pelvis. So she came to me for third opinion. When she showed me the result, I told her this is picture of pregnancy more than hyperprolactinemia. So at that time, I sent her to Dr. Rasha, and she was pregnant and 6 months gestation age.
She didn't feel it?
She did not feel it. And she's seen by 3 doctors actually, around 30 years.
And the fetal.
Actually, there was malformation in the baby because she took a lot of medication during that. There was no pain actually. She sent to 7. No, third day. So first there was no pain actually.
No pain.
Yes, because she received a lot of medication they gave her. Yes. Management of microprolactinoma. For patients with women with microprolactinoma, if there is no symptoms, normal LH and FSH and or postmenopausal stage, and there is no macroprolactinemia, there is adenoma and less than 1 centimeter, some authors said the treatment is not necessary in this case because there's no benefit of the treatment. Especially many studies showed that microprolactinemia will not grow with the time. And there's the risk of the recurrence, it's very rare. So most of the authors, they said there's no treatment for that. But some others, they consider that bone health, because as we mentioned, that hyperprolactinemia by itself, regardless the gonadal function, can cause osteoporosis and osteopenia. So in this case, some authors, they consider to start low dose of dopamine just for prevention of osteoporosis and osteopenia. For symptomatic microprolactinemia, for a patient with infertility, patient with amenorrhea, low LH, FSH, estrogen, progesterone, if there is no plan for the pregnancy, immediate plan for pregnancy, there's no harm to start oral contraceptive pills. No need to start treatment for specific treatment for prolactinoma, because as we mentioned, that the risk of growth of microprolactinoma is very rare, and the oral contraceptive pills, it is safe at least at the next 2 years in this case. If there's a plan for pregnancy, it's better to start dopamine agonist. Dopamine agonist is first line of the treatment, induce apoptosis of lactotroph, and cause rapid prolactin reduction and significant tumor shrinking. For macroprolactinoma, it's better to start directly with dopamine agonist. We have 3 types of dopamine agonists. We have cabergoline. Cabergoline is first line of the treatment, starting dose 0.25 to 0.5 milligram weekly, and standard dose around 0.5 to 3 milligram weekly. We have bromocriptine, 0.625 to 1.25 milligram per day, standard dose 2.5 to 15 milligram per day, maximum dose around 300 milligram per day, and maximum dose of cabergoline around 12 milligram per week. And quinagolide also, starting dose 25 microgram per day, and standard dose 25 to 150 microgram per day. Why we prefer cabergoline? Because the main studies show that cabergoline can cause shrinking in the tumor size by 90% and normalize prolactin level in 95% compared to bromocriptine. Bromocriptine normalized prolactin level in around 75% and shrink the tumor size in 50% of the cases. We have this patient came to my clinic with infertility, actually, with male actually, with hyperprolactinemia. His prolactin level was 500. So you can see in the first visit, there is pituitary adenoma around 1.5 centimeter. We started cabergoline with dose 1 milligram per week, and this is his pituitary gland. After 2 years, there is full recovery of pituitary. There is no evidence of any adenoma. And he got a baby actually after treatment around 6 months. Now, after the initiation of dopamine agonist for follow-up, it's better to do prolactin level after 1 month of the starting therapy. And anytime you change the dose, it's better to repeat the prolactin level after 1 month. If the dose is stable and prolactin is normal, it's better to repeat prolactin level every 3 months. For pituitary MRI, if patient had microadenoma, it's better to repeat pituitary MRI after 1 year. If patient had macroprolactinoma, or there's prolactin still increasing with the time, or there's no new clinical features, it's better to repeat prolactin MRI pituitary every 3 to 6 months. For visual field, it's not necessary to follow up by visual field, only if there's an MRI show there's touching between the optic nerve and adenoma. Dopamine agonist withdrawal protocol. It's safely to stop dopamine therapy for macroprolactinoma after 2 years of the treatment. If patient achieve normal prolactin level and there is significant reduction in tumor volume around more than 50%. And for macroprolactinoma, it's better to continue treatment for lifelong, because the recurrence is related to 2 things: to the size of the adenoma at the time of diagnosis and the level of prolactin at the time of diagnosis. And as we mentioned before, that microprolactinoma is rarely recurrence after 2 years of the treatment. Monitoring after withdrawal of dopamine agonist, First year, we have to monitor by prolactin level only every 3 months. Then after that, every year we do prolactin level. And MRI is not recommended. Only if we see high prolactin level anytime, we have to do MRI again. We have something which is called resistant prolactinoma. Resistant prolactinoma defined if prolactin level not normalized after 6 months of the treatment with maximum dose of dopamine agonist. Maximum dose of dopamine agonist, capregoline 12 milligram per week, promaclopine 30 milligram per day. Or if there is no reduction more than 50% of the tumor size after 6 months of the treatment. In this case, if patient is already taking promaclopine, it's better to switch to capregoline. But there's no benefit to switching from capregoline to promaclopine. Side effects. Common side effects of dopamine agonist include nausea, orthostatic hypotension, nasal congestion, leg cramps, and flushing. Sometimes or rarely that capregoline promaclopine can exacerbate psychosis or major depression in patients who have already background of that. But the most important side effects related to the cardiac valvopathy. Most of the studies that showed that risk of cardiac valvopathy is very rare or very low with standard dose. However, the guidelines recommend to do screening echocardiogram before starting capregoline or promaclopine. If patient is taking capregoline less than 2 milligram per week, it's better to do echocardiogram every 5 years. If patient is taking more than 2 milligram per week, it's better to do echocardiogram every year. For resistant hyperprolactinemia or resistant prolactinoma, we have another choice of therapy. We have somatostatin analogs like octreotide or lanreotide, but it is only there's 2 cases report showed benefit for that. So the evidence level is very low in this case. Also because we mentioned that estrogen can stimulate prolactin secretion, so there's benefit from anti-estrogen modulation. Usually there's some case reports about aromatase inhibitors, selective estrogen receptors modulators, but it's not recommended in the guidelines right now. Another advanced therapy for resistant prolactinomas, we have surgery, transsphenoidal surgery for resistant prolactinoma not responding to medication. And the third line of the treatment, if there's recurrence after the surgery, we use radiotherapy, stereotaxy by gamma knife, but it takes too long time to reach the maximum effect, around more than 20 years. Also, we have to differentiate between resistant prolactinoma or dopamine agonist intolerance. So if patient develops side effect related to capregoline, that does not mean there is resistant for medicine. Treatment of stroke effect, as we mentioned, any lesion or injury in the pituitary stalk will increase prolactin level. In this case, the treatment is related to the underlying cause. If there is any adenoma, non-functioning adenoma, or adenoma-secreting GH or any other hormone, the treatment is surgical treatment for underlying disease. If there is no indication for the surgery, like non-functioning adenoma and less than 1 centimeter and no symptoms, in this case, if the prolactin level cause hypogonadism, it's better to start oral contraceptives in men or in women or testosterone in men. If there's galactorrhea, we can give low dose of dopamine agonist. Management of drug-induced hyperprolactinemia. The best treatment for that to stop that medication, which can cause hyperprolactinemia. In most of the cases, we cannot stop that. So in this case, we can start with low dose of dopamine agonist like capregoline, promaclopine, but we have to be careful about that because, as we mentioned, that promaclopine, capregoline can exacerbate the psychosis or major depression. In all cases, this treatment can normalize prolactin level in 75% only, 25 even with high dose of dopamine agonist, prolactin is still high. There is no benefit to decrease the medication dose because this effect is not related to dose. Finally, this is the biggest prolactinoma I have seen. This is a French patient. Diagnosis and treatment was done first in France, but now he's following my clinic. Actually, this 35 years old male, he does not have any symptoms related to the prolactin. He does not have infertility. He does not have anything actually, even no headache. Only he presents there with epileptic disorder like temporal loop, the manifesting by or as Dojovo phenomenon only. So they do MRI. They found there's very big mass pituitary, and initial prolactin was 33,000 the initial prolactin level. The maximum or reference range around 15, the upper limit. So it was 33,000. So in this case, they start with 6 milligram cabergoline per week, and this is his imaging after 6 months. There's significant reduction in prolactinoma size. Interestingly, that patient does not have any other hormonal disorder or deficiencies. No hypoadrenalism, TSH, 54, or testosterone, all is normal. Testosterone was related to the low suppression of prolactin effect, not related to the mass effect, actually. It restored the testosterone level after the treatment with cabergoline. It's not touched, actually. Thank you.